My name is Siddhartha. I'm an interventionalist in Raleigh, North Carolina. I'm going to present a couple of cases here. First one's a 61-year-old white male. Usual risk factors. This guy's very functional. He's actually a mechanical engineer. He got married last year. He presented with rest pain and right second and third toe gangrene. His non-invasive studies were absolutely abysmal. He basically had little to no flow in his toes. I've kind of put the stuff up there. So we'll get to the meat of the issue here. So this is his diagnostic angiogram. And I didn't slow this down or anything like that. This is with a catheter in the P2 segment of the popliteal artery, and this is what's reaching his foot. And then when you look up higher, it's not a whole lot better either. When you look at flow, really is terrible flow. So his perineal's diffusely diseased, occluded. He's got a tight stenosis in the posterior tibial, and the anterior tibial is occluded above the ankle. So he had been offered BKA, so he came to me for a second opinion. And this is with the catheter, the P2 segment of the popliteal artery. So not a whole lot of flow-limiting disease, either by ultrasound or by angiography. But his real problem was everything below the ankle. So when he came and saw me, obviously there's some decisions to be made. How do you revascularize him? What do you do? So I always, like everybody else in this room, try to recanalize the native vessels. But you can see with the video on the right side, I could hardly penetrate the plantar vessels with multiple wires. I mean, I just could not. I tried multiple wires, and there's nothing that was going to go. So now the question is, what do you do? Are there surgical targets for revascularization? Is there anything else you can do endovascularly? Do you just let him get a minor amputation and see if that heals up, or do you, relegate him to a major amputation? And since he was such a functional guy and otherwise healthy, we said, let's see if we can do something else here. And is Dr. Coombe here? So let's take a look at what kind of patients you get for major amputations. This is a North Carolina database, and actually it's not the older person that has 2,000 medical comorbidities who can barely talk who gets a major amputation only. A lot of these patients are private paying patients, and when you look at the data further, they're usually in a very productive part of their life. Half of these people are very, very, very productive. They are 45 to 65. So I said, okay, well, maybe then we need to try to proceed with some deep vein arterialization action here. So what does that do? So you basically arterialize the venous arch and hope that there's enough perfusion now into the foot that you can heal up the wound. Dr. Coombe, who's actually, I guess one of our panelists, or going to be one of our panelists, wrote up a nice paper from Singapore. And then one of our co-authors for this paper is actually sitting there in the back for the PROMISE 1 trial. So there are commercial and non-commercial devices available to do this. So this is what we decided to do. So you access the posterior tibial vein. You may have kind of snuck a peek of the wire actually from the vein going up in my diagnostic pictures. You put up a 560 or a 540 balloon, and then in my practice, I've done about 13 of these, I think, now in the last 2 years. I usually prep the posterior tibial artery with orbital atherectomy so that the outback catheter can actually puncture through and through the artery into the vein. My third case, I actually failed when I tried to do this because there was so much calcium in the posterior tibial artery, the outback wouldn't puncture it. So my technique has gotten a little bit more refined over the years. So diamond back that, and then, and this is the most visceral part of the case. There are few things that give you as much pleasure as seeing this happen. There you go. So there's that 21 gauge needle, burst the balloon, then you prolapse your wire into the vein, and then you dilate the channel you've created between the artery and the vein. And then it's not always easy to cross these valves. They can prove to be a little bit of a hassle, but once you've done a few, then you get the hang of it. There's just no easy way. And you get your wire into the pedal venous arch, if you can, and then you crush the valves. So I typically just use regular balloons to crush these valves. Sometimes I'll use chocolate balloons, especially across the AV site. And then once you do that, you have to line it with a stent graft. So you put a Vibond below the ankle, extend it above, and this Vibond has to cross over into your arterial system. So once you do this and post-dilate it, you get a really, really nice result. So I've spent some time training my techs. There are two of my techs that I do these procedures with now, and these guys have gotten so good. I don't need to tell them what the next step is. So this was skin to skin in 90 minutes. So if you look at the subtracted image, this is what we started with absolutely no flow to this cold foot. And then at the end of the procedure, after dilating the pedal venous arch and extending your Vibond down below the ankle past the terminal valve, you have this plethora of flow up to the midfoot. And after he went to the OR, when the surgeon did a proximal transmetatarsal amputation, he got no blood flow. And then I told him to go a little higher to about a Liszt-Franks level, and he bled like there was no tomorrow. So usually they end up getting a wound vac, and wounds do take slightly longer to heal. But the way I look at it, in my experience, I've had about a 70% limb salvage rate with this. So there's still some people who get a BK after this, but if I didn't do this, the way I look at it, 100% of them get a BK or an AKA. So that's my first case, and I'm going to breeze through the second one. This is more of a problem-solving kind of case. So this was a very functional lady who lived by herself, older, very frail, COPD, congestive heart failure, gangrene of the right hallux, again, very terrible looking arterial duplex. So when you look at her angiogram, she's got diffuse femoropopliteal disease, and then the pop is occluded at P2 and barely recanalizes at the level of the tibial vessels. So I had done a diagnostic on her, so I went in fully prepared. So I had antegrade CFA access, and I had pedal access from both the AT and the PT. So I don't know if this projects very well, but parallel to the peroneal artery is a wire coming from the antegrade route. So that wire actually went outside the vessel. And then this is from the posterior tibial. This went outside the vessel too. So luckily I had my third access point. So I pushed through an 18,000 wire and a catheter from the anterior tibial route. And then I say, okay, I'm home free because the catheter and wire's like really sliding through, but no such luck. Everything was in the subintimal space. And this is when all hell broke loose. So the fluoro subtract and smart mask in my lab stopped working. And the only thing that could have been done to restore it was a hard reboot, and the patient was on the table with a wire in her subintimal space from below, and that's it. So I said, boy, how do I get out of this situation now? So the fluoro was still working, just the plain fluoro. So I said, okay, I just need something that looks radio opaque to guide me. So I put a 6mm balloon down in the SFA, and I actually punctured my way from the subintimal space with an anterior wire. So this is not quite as pleasing when you puncture this balloon with an anterior wire as it does with an outback, but you can tell the anterior wire, there's a give to it. And once I knew I was back into the true lumen, then you just advance your V18 or whatever wire you use, and then you externalize it through the existing sheath. So I typically don't use snares anymore. I just put a short sheath that's one size, one French less. And then when you push your J-tipped wire into that sheath, you can just externalize the sheath. So this is the cheapest snare you can get. So now you're flossed. So I usually IVUS all my cases, hawk the lesion, even though I was subintimal, very carefully. And then one stent later, this is how it looked. So that's the femoropopliteal segment. Now we're getting to the pop bifurcation. And then this is flow through the foot. Now, I typically do a lot of my pedal access cases sheathless. I mean, you can push a lot of balloons, 018 compatible, 014 compatible balloons, actually sheathless, without a sheath. I just like having this picture where you can show a lot of flow into the foot at the end of the case. So needless to say, this lady also we were able to save. So that's kind of what I have for you, a couple of below the knee cases.